to introduce Dr. Vita Henderson, who has been a wonderful addition to the faculty and PHS here. Vita has a long history of work in cancer disparities and health equities, and actually has a PhD in pharmacy from the Xavier University in Louisiana way back in 2000, but much more recently has a Master of Public Health from the University of Michigan and a PhD in Community Health Services from the University of Illinois. And she has been doing many projects here and elsewhere, and we are just really fortunate to have her in our orbit. Thanks, Vita, for being willing to speak at these noon seminars, which I hope in the future will be in person.
Well, thank you so much for inviting me. I really appreciate it. And I'm looking forward to meeting more of you. It's been a weird time to start a new position at Fred Hutch. So I still haven't met a lot of people, but hopefully that'll change soon. But today I'm going to talk about two studies. Both of them focused on facilitating decision-making about breast care with culturally responsive narrative interventions. And when I say narrative, I mean storytelling. So we'll talk about just the development process and how we do that and how we use community engaged approaches to do that to address breast cancer disparities. And the picture you're seeing on the screen is a picture of a story circle that we recently conducted in Chicago with one of our breast cancer advocacy groups. And the person facilitating is actually a breast cancer survivor who's part of that group, who we trained in doing some of our methodology. And I'll talk about that project in a little bit. But the first project I'll talk about is helping patients make decisions about genetic counseling and testing, Black patients who screen at higher genetic risk for developing breast cancer. And the second project that I'll talk about is focused on facilitating decision-making about clinical trial participation among Black patients with breast cancer. So hopefully you can see my screen okay. So first I wanted to tell you a little bit about my research program. My work primarily focuses on addressing cancer inequities among underrepresented communities that experience disproportionate cancer burden. I aim to understand how the social determinants of health impact access and use of healthcare services, and then develop interventions to address those identified barriers. My work has largely focused on implementing quality improvement programs for cancer screening in federally qualified health centers, and conducting health communication research using community engaged approaches. And I talked about the two studies that I'll focus on, so I'll just jump into that. So I'm not sure the makeup of who's in this meeting today, but just a little background. Genetic counseling and testing is recommended as standard of care. And the U.S. Preventive Services Task Force guidelines recommend incorporating assessment of family history into routine primary health care in order to identify women who are at risk for hereditary cancer so that we can make appropriate referrals for genetic screening. And the NCCN provides guidelines for pre-test genetic counseling, and they also provide guidance on when genetic testing should be performed, and also emphasizes using genetic testing as an aid for therapeutic decision-making. So there's a number of benefits and limitations associated with genetic services for individuals with increased risk but have yet to be diagnosed or have not been diagnosed. Genetic screening can help them make decisions about preventive actions such as starting mammograms at an earlier age or doing them more frequently, attaining additional screening with the breast MRI, taking medications that lower breast cancer risk, getting preventive surgery, and even initiating lifestyle modifications. And for individuals with a personal history of cancer, genetic testing can inform individualized treatment decisions. It may inform eligibility for certain clinical trials, and it can help patients understand their risk for developing additional cancers and guide those risk reduction strategies that I just talked about. And regardless of diagnosis status, genetic services can inform family members about their cancer risk as well, and help them implement risk reduction strategies. And some of the limitations of genetic counseling and testing is that not everyone's a candidate. It can be expensive if it's not covered by insurance. It doesn't always provide an answer about cancer within a family, and there also may be stress or guilt associated with disclosing your risk to other family members who might also be at risk. So that can be stressful for some people. As we know, about 10% of breast cancers are due to inherited genetic mutations. And those in that 10% have a much, much higher risk of developing breast cancer compared to the general population. But unfortunately, the vast majority of people with these mutations have yet to be identified, or they're never identified. And importantly, for women with breast cancer, the rate of some of these genetic mutations is comparable regardless of race, but the issue is patients don't receive genetic services consistently or equitably. As we all know, Black women are 41% more likely to die from breast cancer than white women, and have the highest death rates from breast cancer than any other race or ethnicity. And they frequently share breast cancer features that are associated with BRCA1 mutations. For example, a younger age at onset, higher tumor grade, a higher rate of having negative hormone receptor status. And Black women also have higher rates of variants of unknown significance. In relation to genetic services, Black women are 72% less likely to receive genetic counseling than white women. They're 44% less likely to have genetic testing recommended by a provider, and 56% less likely to have genetic testing performed. So underutilization of these breast genetic services is due to multi-level modifiable factors, such as provider referrals, lack of provider referrals, just lack of the perceived benefits of getting these services. And also access to and awareness of genetic services. There could be fear associated, and also people are scared of the cost. They aren't sure what this would cost them. And so all of these factors underscore the importance of increasing uptake of genetic counseling and testing among Black women who may be at increased risk. So last year, a report was released by advisors to the president with the president's cancer panel, and they gave 4 recommendations for decreasing cancer disparities in terms of prevention. So goals 1 and 2, which aren't on the slides, are focused on developing effective communications about cancer screenings to reach all populations. And interestingly, goal 3 is to strengthen workforce collaborations to support risk assessment and to expand access to genetic testing and counseling. And goal 4 was to create HIT, which is health information technology, that promotes appropriate cancer risk assessment and screening with an emphasis on decision support tools. And that'll bring me to the project that I'll present. Health information technology refers to electronic systems that we can use to share, store, and analyze health information. And health information technology really helps us address a number of factors associated with cancer disparities, such as health literacy, language, and facilitating knowledge and behavior change. And cultural targeting or tailoring, sometimes people use those terms interchangeably, is the development of an intervention that incorporates shared characteristics among a specific subgroup. So programs and interventions that are culturally responsive have been shown to be more effective in promoting behavior change and decision support. So all of this leads me to the development and testing of a culturally targeted decision aid video that our team developed to help guide decisions around utilization of genetic counseling among high-risk Black women. So a lot of my work focuses on health communication research and decision aid development. And patient decision aids are tools that help patients and providers talk together about their care options. Decision aids help patients understand their choices about whether to have a specific treatment or screening. And this includes knowing the pros and cons of the available options. They also provide patients with information needed to make decisions based on their own personal values and their own preferences. By exploring each option and really evaluating how this aligns with their values and their preferences. And research shows that patient decision aids do lead to increased knowledge and a more accurate understanding of risk. And that when using decision aid tools, more patients feel comfortable with the decisions that they make and the care that they receive. And they can be in print, like brochures, decision trees, or they could be digital or web-based, like websites, computer programs, apps, videos. So the two that I'll talk about today are actually decision aid videos. So this figure represents the development model that our team uses to produce decision aid tools. Our model is adapted from the International Patient Decision Aid Development Model created by Whitman et al., where first we aim to understand the experiences, the needs, the barriers of the end users, the people who we're designing these tools for. And then we use that information to actually develop the decision aid. And then we go back to those users just in iterative cycles for feedback on the components and the content until we reach a final product. And then we pilot test the tool in the appropriate setting. So our team's model differs from Whitman in that we aim to produce decision aids that are culturally tailored and are delivered using low-cost, accessible technology. And we also know from prior research that people are more motivated to engage in health behavior if they're emotionally triggered or engaged to do so. And to this end, that's the reason we incorporate aspects of storytelling to motivate positive behavior change. And then finally, we've aimed to design decision aid interventions that can be implemented in either or both a clinical setting and a community setting. So which hopefully facilitates dissemination and diffusion of knowledge throughout communities and social networks, but can also be a tool that can be integrated into standard clinical practice that can increase knowledge and awareness of whatever that particular focus area is, and help patients decide whether getting a particular health service is right for them or not in the clinic and when they're discussing things with their provider. So it really just helps patients make really informed choices and helps facilitate that communication with their providers. I talked about creating decision aid tools that are culturally tailored and responsive to users' needs. Matthew Kruder is a well-known health communication researcher, and he developed 5 strategies for enhancing cultural appropriateness that we utilize in our work. So in general, we as researchers, we want to make sure we're developing tools that are packaged using images and design features that appeal to a particular group. So basically, people just want to see people that look like them when we're developing these tools. We want to use evidence and data that's relevant and representative to that group. Obviously, we want to use language-specific tools. And I think one of the most important things that we do is directly incorporate the experiences that we learn from talking with people and talking with these groups and all of our qualitative work into the intervention design, and really conveying the social and cultural context that are relevant to that particular thing that we're focusing on. So the first study, again, that I'll talk about is called the PRIDE study. And this is a randomized control study to test the efficacy of our decision aid video on promoting awareness and use of genetic services, again, among Black people who are screened and identified as being higher risk for genetic breast cancer. So I'll talk about the development process and where we are now with this study. So these are wonderful team members for the PRIDE study. This study is being conducted at Miles Square Federally Qualified Health Center in Chicago. And it's a group of, I think it's 14 now, FQHCs that make up Miles Square. We're doing it in one location. And it's part of the University of Illinois hospital system, which is a large academic hospital system, but has these FQHCs integrated as part of it. And at Miles Square, over 95% of patients seen are racial and ethnic minorities, and 75% of the patients are either uninsured or publicly insured. And as an FQHC, the clinic serves all patients regardless of their ability to pay. But before I go into the nuts and bolts of the randomized controlled trial, I'll talk a little bit about preliminary studies. So prior to the PRIDE study, to inform content and development of the decision aid, we recruited Black women with a family history of breast cancer from a previous study to participate in one-on-one in-depth interviews and story circles. And the goals of the interviews were to learn about personal beliefs and experiences related to breast cancer and breast cancer risk. And the goal of the story circles were to learn more about family-related experiences and beliefs about cancer. So we conducted all of this qualitative work, and then we triangulated the themes from both the interviews and the story circles to create the storyline, the messaging, and the educational content that was part of the narrative of the video. And then after that, we conducted a series of multiple focus groups with another set of Black women who had a family history of breast cancer, and also with healthcare providers from Miles Square and representatives from the community, from community-based organizations, and to get iterative feedback first on the script, the storylines, the storyboards, and then eventually the final video product. And that's kind of the process that I just described when I was talking about the model that we use. So creation of this intervention was guided by the integrative model of behavioral prediction. And basically, as a behavioral scientist, we do everything with these theoretical frameworks, but basically asserts that the primary driver of engaging a health behavior is forming the intention to do so. So we really focused with this intervention on changing people's intention to get genetic counseling. But we know even if the intention is there, there may be other multi-level factors that either prevent or help a person engage in a particular health behavior. So this just gives an overview of the themes that we found that are mapped to our theoretical constructs. So specific quotes and experiences elicited from participants during their story circles and interviews were incorporated into the script whenever possible. So again, that it would accurately reflect the lived experiences of the target audience of the people that we're focused on. And very briefly, the things that we found were that women equated genetic counseling with getting a cancer diagnosis, that they thought the whole purpose of the counseling was they would be told that they have cancer. They expressed that there is poor trust and communication with providers. There's a lack of understanding and knowledge about genetic counseling. There were concerns about cost and insurance coverage. And then religion and spirituality came up a lot in positive and negative ways. People viewed their spirituality with either helping them cope with cancer and cancer in the family or as a punishment. And then finally, I know in this study and almost all the studies that I do with Black women and cancer, family secrecy always comes up a lot. So there's a lot of family secrecy around cancer, whether it's some form of shame or not wanting to be a burden to your family. So that came up a lot. So I already described the process of how the interviews, the focus groups, and all of that, how that was used to inform the script and the storyline. And just to show the importance of actually talking to people when we develop interventions and programs, we originally thought that we would do the video would be either all animations or we'd have that whiteboard style with the hand drawing while people were talking. But when we show people that style of video, they hated it. And they really preferred the more narrative story, and they wanted a mix of real actors and animations. So we ended up with a really different tool than what we had originally thought, which was great for us. And once we conducted all of those focus groups with different cohorts, like I said, the providers, patients, advocates, people seem to be really happy with it. And I'll show maybe 2 minutes of the video just so you can have an idea of what I'm talking about. It's a 6-minute video, so I won't play all of it, but just to let you know what the content is. It talks about the purpose and benefits of genetic counseling. It defines what a cancer genetic risk assessment is, describes the role of a genetic counselor, overcoming some of the barriers that we heard, and the importance of sharing information with others. So let's see, hopefully this works.
Hey, thanks for coming to the party.
I wouldn't have missed it. It's been forever since we've seen each other. How you been?
I'm all right.
Is something wrong?
I'm fine. But my doctor said I should do something called genetic counseling because women in my family get breast cancer and ovarian cancer. I'm not going. I already know that cancer runs in my family and that I'm probably going to get it someday. So what's the point? I get my mammogram every year. What else can I do?
Breast cancer runs in our family too. My doctor told me the same thing and I didn't want to go either. I was scared to hear what they had to say about it, but I went anyway.
Girl, I never even heard of genetic counseling. What happened when you went?
Well, what am I doing here? I'd rather not know anything about this. No news is good news, right? I should have had someone to come with me, but I don't want my family to worry about me. As a matter of fact, I don't want them in my business anyway.
You may be wondering what happens at a genetic counseling appointment. It's really just a conversation with someone who's an expert in helping you understand how conditions like cancer can run in families. They'll ask questions to learn more about your family's experience with cancer and to figure out how that relates to your chance of getting breast cancer in the future. Most importantly, you'll get information that will give you the power to make the best decisions for your health. Genetic counseling does not tell you that you have cancer, and it doesn't tell you that you'll definitely get it someday. Think about it this way. Cancer's like the weather. There's always a chance it will rain, but the chance is higher on some days than others. And all women have a chance of getting breast cancer, but some women's chances are higher than others. Genetic counseling is like watching the weather report. You watch it so you can make the best decisions for the future. Like deciding whether to have a house party or a backyard barbecue for your cousin Felicia's birthday party.
Girl, don't you ever watch the weather report?
The information you get from genetic counseling.
So for the sake of time, I won't show the whole thing, but hopefully you could see how we incorporated some of the things that I just talked about and some of the things that we heard into the script and the storyline. And again, it's 6 minutes. It's a little longer than we wanted it to be, but I've heard that it doesn't feel like 6 minutes. And I meant to put the QR code on the screen if anybody wants to see it, but if they want to see the whole thing, I'm happy to share the link with you all. So after we developed the video, we did a pilot study with 30 women to test the feasibility of conducting this study and using this as a tool in the mammography clinic at UIC, or University of Illinois. And so we recruited women who were coming in for their mammogram. They, as part of check-in standard of care, they did the cancer genetic risk assessment, and those who were flagged as high risk were notified. The mammography tech, after she did the mammogram, she let them know about our study, handed them a flyer, and then we conducted the study, which was, for this pilot study, it was a pre-test. They watched the video, then a post-test. And then after that, we gave them, if they were interested in making a genetic counseling appointment, we gave them information to make that appointment. And then we intended to do a 3-month follow-up. Unfortunately, this was around the time of COVID. So when we did the 3-month follow-up, it fell into like the beginning of 2020. So at the time, we didn't know I think when we looked at it, no one had made an appointment. So we can't tell if it's just that this intervention didn't work or if, you know, it was related to COVID, but that's why we're conducting the randomized controlled trial now. But what we did find was that from the pre and post test, was that intention to make a genetic counseling appointment increased significantly post-intervention. And we also found that certain self-efficacy beliefs like knowing who to call to make an appointment, the ability to pay for services, and knowing who to call and having the ability to pay for services significantly increased post-intervention. And patients also felt that their family members would be interested in learning more about genetic counseling. And finally, the vast majority of women had extremely favorable views of the video and said that they would share it with their family. So finally, we're at the PRIDE study. So this is a stage where we're testing the efficacy of the decision aid video and whether or not patients attended a genetic counseling appointment. And so we're gonna compare the effects of the video and a genetic counseling educational brochure that was developed by a national organization on genetic counseling attendance, again, among Black women identified to be at higher risk for breast cancer. And the screening tool that we're using is Cancer IQ. Different from the pilot, we're actually conducting the RCT in primary care, in a primary care clinic at Mouse Square. So it's a little bit of a different patient population. So we're gonna see how that goes. And we're working with 4 providers. And so patients come in, we screen them. Everybody who hasn't had a risk assessment within the last year, we screen them, and then we see if they're potentially eligible for the study. And then after their visit, we approach them, and if they consent, then we conduct the study. Very similar methodology to the pilot. In this study, we'll also assess if certain psychosocial factors such as distress and risk perception impact the association between the intervention exposures and genetic counseling attendance. And then finally, we'll do a 4-week follow-up phone call with each participant to understand if they shared information about genetic risk with their families or social networks. And if so, who and what information did they share? And we hope that that information will help us just understand how people talk about this information and how they influence other family members who might also be at risk. That could help us maybe design future work for cascade genetic testing. And this is just a schematic of the intervention procedures that I just described. And the goal is to conduct a study with 152 eligible patients. And again, we have it kind of integrated into the clinical care where the navigators communicate with the providers through Epic and let them know that, hey, this person screened at higher risk, and hey, this person might be eligible for the study. So we're working closely, like I said, with 4 specific providers to screen and recruit patients. So that was that study. The next study that I'll talk about is currently also underway and is focused on facilitating decision-making and increasing enrollment in clinical trials among Black women who are diagnosed with breast cancer. And this is called the For Me study. This project is a collaboration between a number of research, clinical, and community partners. And our amazing team comprises public health researchers and oncologists from Fred Hutch, University of Illinois, and Mount Sinai Hospital in Chicago. And Mount Sinai is also a safety net hospital that serves communities on the south and west sides of Chicago who are disproportionately impacted by cancer. This study also uses aspects of community-based participatory approaches, and we're collaborating with community partners that we've had a long-standing relationship with. And that first slide I showed you, again, was one of the story circles that I think that was last month, or I think it was last month. And that was for this study that they were conducting those story circles with those breast cancer survivors. And so we know increasing diversity and representation in clinical trials is being recognized as a priority focus across multiple health sectors, and there's a lot of focus on this right now. And eligible Black patients are significantly less likely than white patients to be enrolled in clinical trials that lead to FDA-approved cancer therapeutics. And this results in reduced access to breakthrough treatments. And it also limits the validity of the generalizability of the results in these studies, and it highlights the inequities in access to high quality care for racial and ethnic minorities that are often linked to social and systemic barriers. So again, the overall objective is to help patients make decisions about participating in clinical trials with a culturally tailored decision aid video. For aims 1 and 2, using a CBPR or community-based participatory approach, we conducted one-on-one interviews and story circles and focus groups to first understand the experiences, the priorities, and values of Black patients who have been diagnosed with breast cancer in relation to clinical trials. And then we also sought to understand the perspectives of oncologists, clinical trial staff, and community advocates. So we did interviews with all of these people. And that's where we are right now. That's as far as we've gotten in this project. But we'll then use that information to, again, develop that narrative decision aid intervention using the storyline, languages, images, and making sure that it's relevant and authentic to the people who we talk to. And then for AIM 3A, we'll conduct an acceptability study with 30 Black breast cancer patients in the University of Illinois Hematology Oncology Clinic. They'll take a pre-survey using the acceptability scale, and they'll watch the video and take a post-survey. So as standard of care in this clinic, all new breast cancer patients meet with a breast cancer nurse navigator to provide standardized patient education materials. So for this pilot study, we'll incorporate that video intervention into the educational program that the navigators deliver. And they'll look at it on a computer tablet. And again, it'll be part of that initial educational consult. And then for AIM 3B, we'll conduct a quasi-experimental pilot study where we'll do pre and post-test intervention analysis, and we'll compare the rate of therapeutic and non-therapeutic clinical trial participation among Black breast cancer patients over 12 months prior to starting the intervention, and 12 months post-intervention, where again, we'll incorporate that video into that educational consult component when patients are diagnosed with breast cancer. So we'll compare the rates pre-intervention and post-intervention for 12 months for each period. So again, our project is developed by, is guided by this integrated framework, one that I just talked to you about, where intention is a primary driver, but we're also incorporating it with the model for analysis of population health and health disparities, which we can also refer to as the Warnke model. But that focuses on the multi-level fundamental causes that influence health outcomes and health behaviors. And fundamental causes include biological pathways and many of those social determinants of health that span individual, community, structural, and institutional factors. So in a nutshell, although deciding whether or not to participate in a clinical trial is without context an individual decision, that decision is based on a multitude of other factors that reside outside of an individual. So addressing health behavior issues and public health just at the individual level without that social and institutional context is really insufficient. So aligned with our framework, we organized and designed our AIM 1 interview guides or questions to get at those multiple ecological levels to comprehensively understand all of the factors that impact decisions and abilities to participate in clinical trials. So we actually designed different interview and focus group guides for patients, providers, and advocates. So each cohort had their own set of questions to get at those contextual factors related to participation at those different ecological levels. So for example, to assess institutional level barriers, one question that we ask patients is, have you ever experienced times when you felt that you were being mistreated, unheard, or felt you were getting less quality care while getting health care? Would you tell me about that? How, if at all, has that experience impacted the way you feel about healthcare providers or the healthcare system? So right now, as I said, we've conducted 30 patient interviews. We've conducted 20 provider interviews with oncologists and clinical trial staff. We are still conducting community partner interviews. We've completed 12 out of 20, and we've completed 3 story circles with 20 participants. So we're still very much in the data gathering stage for this project. And our next steps is to analyze our data, develop that script and storyline. We'll go through that iterative process again with multiple iterations and for focus groups on this content and then on the actual tool. We'll do revisions, production, and then we will do the intervention implementation. And the last thing that I'll talk about is the For Us study, which is an extension of the For Me study. And the reason for this, when it comes to public health information, we know dissemination efforts tend to be passive or are limited to academic methods of dissemination, like conferences and publications. And a lot of times communities and community members might not ever see or have access to that information. And then dissemination rarely involves efforts to engage non-research audiences and the end users, and just the general public in developing effective messaging. So this is also problematic in the decision-making processes associated with clinical trial participations. Patients don't often make these decisions by themselves. They consult family members, friends. So it's important that everyone has access to this information. So our team thought that marketing communication strategies that are typically employed in business may be particularly effective in closing health information gaps. And so a funding opportunity came out last summer from the V Foundation, specifically to fund research that was aimed at promoting clinical trial participation among Black cancer patients. So our team thought this was a great opportunity just to disseminate information outside of academic walls and take a more active approach to give this information to broader audiences. So right now we're working with a professional marketing agency here in Seattle who helped us conduct additional market research using focus groups with broader audiences of Black community members and family members, and also caregivers of cancer survivors to inform the development of a public service announcement. So we have, we're pretty far with that. We've developed the script storyline, we've tested it in our first set of focus groups, and we plan to actually film it in 2 weeks. So we're really excited about that. And we've been in contact with a national broadcasting channel company who we hope will broadcast this as a national commercial throughout the year. So I think that is my last slide, and I'll be happy to try to answer any questions or just hear any ideas you have with your own work. And yeah, I'll open it up. Am I calling on people? Y'all can just talk. I think somebody is there.
Hi, I have
Hi.
a question for you. This is Ben Anderson, and I'm actually not at Hutch, but I used to be. I thought that was really well presented. It's a great project and a ton of work. So I really want to congratulate you on what you've been doing.
Thank
My
you.
question is, I've been listening to discussions about obstacles to care in underserved communities, both in the urban setting and in the rural setting. And there are differences between those, but one of the similarities is trust issues, having trust of the health system or the person you're working with or electronics. There's a whole, trust is a really consistent theme. My question is, you mentioned that after in the context of the first study, can you measure trust? And do you have some questions that get at that, or is that and could you measure trust before and after your video as an example? Once again, it was a great presentation.
Oh, thank you. I actually, as I'm thinking about future studies, we've never measured trust, but I have looked and there are some validated scales that do measure trust. I don't know how well they work or not, because I haven't actually used them yet. And you're absolutely right. Like, I can't directly quote it, but I do remember in our focus groups, people said, people are not going to participate in a clinical trial if they don't trust their provider. It's like number one key is trust, like you said. So one of the things that I'm interested in exploring is this whole aspect of storytelling. Can storytelling build trust? Can some kind of way, can that make a bridge between a provider and a patient in their communication with this idea of storytelling, seeing people who look like you, hearing stories and characters who remind you of your own family experiences that you have? Can these narrative interventions somehow bridge trust? So that's one of the things I'm really interested in future work. So I don't know,
one reason to think about it is that if your project is like any other project I've ever done, there will be mixed results. You know, there'll be some successes and some not so much successes. Being able to correlate it with trust might be a way of helping to understand why did it not work here as well as somewhere else. Anyway, just a thought. And once again, great job.
Thank you. And I appreciate that comment.
I can speak. Dr. It's really excellent work. I love your Talk to a Genetic Counselor video, it's so clear you've done all the work to address all of the concerns and it addresses those. I want to know more about dissemination. You know, this is a tool that works really well, and you're doing just such excellent work in making these and understanding the concerns and creating materials. What type of what's the plan for dissemination, and what partners do you have, and how can we as a community help disseminate this better?
Yeah, so right now, again, we're doing the RCT to just see, does this work? But either way, I think whether or not it promotes people to actually get genetic counseling, we've heard so much like positive feedback from it, and we've shown it to so many different community organizations. We've shown it to people who participated in the prior work. And when somebody asks to use it and disseminate it with their community organizations, we let them. And so we've disseminated it and used it with quite a few community organizations who've asked to use it in whatever events that they're throwing. We also hope that this will be, again, integrated as established into clinical practice. So that's another way. Clinics I've talked about, you know, showing it on the screen when people are in the waiting room. So there's different ways, like I said, actually using it in clinical practice and disseminating it in community. When we conduct the study, people get a QR code. So if they're randomized to that arm, they can watch it whenever they want. And one of the things we're doing with the whole AIM-3 with the social network analysis is seeing, did they share this with other family members or friends? Did they talk about it? So we're we're exploring how people disseminate information. We're making it widely available to whoever wants to use it. If somebody here wants to use it or integrate it, you're more than welcome to. So I think just different approaches, but I do think that's so important, again, when you're doing this community engaged work, to share it and make sure that it is widely available and accessible. And that's the whole point of it. So we would just want to make sure that people have access to it as much as possible. With the second study, again, that might be a national PSA that's going to be shared nationally, but we're also working with a marketing agency who will give us like a dissemination plan and help us really determine what social media outlets this can be posted on, where we might get the most reach. With that second project, we're developing 3 different time versions of the video. So a longer one and then shorter snippets of one, so that we can, test this dissemination in several different ways. And we hope to actually try to measure that this time, which we didn't do that with the first study.
It'll be interesting. Thank you.
Thanks.
Vida, I have a couple questions for you. That was really great presentation, like really high impact, like these 3 different projects. Around the trial enrollment, for me, a project that you're working on, when you're developing, I guess you're not at the stage yet, but as you develop the videos for, you mentioned non-therapeutic and therapeutic trials, is the goal to make them general enough that they could apply, like, I guess you're focusing on breast cancer, but they could apply to any type of, non-therapeutic or therapeutic trial that a breast cancer patient might enroll in? Going to Brian's point earlier about ultimate dissemination and being able to disseminate.
Yeah, so this particular project will be very general, to where it can apply to any clinical trial. Like, it's just an introduction, like what is a clinical trial, But interestingly, also future work that I'm thinking about and talking about now is making that a little bit more specific. And so exploring ways where we can, even if you're just talking about what is a clinical trial and helping somebody understand informed consent, how do you make that part like generalizable in this storytelling narrative format, but then tack on this piece where it's more specific to a specific study? So this particular, for the For Me, it'll be more generalized, but I do have plans to figure out a way to make it more specific. So if an investigator wants to recruit for their particular clinical trial, how can we use some of these techniques to educate people about clinical trials, what they are, and then make it also specific and tailored to a specific study? Does that answer?
Yeah, definitely. I think having both of those things makes a lot of sense, but also and having specific, will probably be helpful, but may not always be available for every single study. But it sounds great.
Thank you. In the chat. I mostly, I'll read the comment. VP at Forest, who worked over 25 years with Mary Caraclain, great talk, amazing work. Would love to see genetic counseling and testing video for men. Is this something that you may consider in the future? I consider everything. I mostly do work with breast cancer, but I am open. I think the great thing about these tools is that they can be so adaptable and into different types of cancers, different populations. So I definitely think all of that is important. And like I said, nothing's off the table. So as opportunities arise, I will certainly consider that. And I don't know if I mentioned, but the control arm is the Force brochure that we're using. So, and they are a wonderful organization. So yeah.
Oh, I didn't know that. That's great. Thank you.
Yeah. Yeah. So thank you for making that available. I think you guys offer it for free. You get these beautiful brochures. So yeah, I talked and got permission to use them a while back. So I'm thankful for that.
Yeah, great work. And yeah, like I said, I would love to see something similar for men because, they're probably even a harder population to reach.
Yeah, absolutely.
Yeah, thank you. Great
Thanks.
talk.
Thank you.